Welcome to Surgical Insights with Dr. Deepz. Today I'm going to simplify one of the most commonly tested electrolyte disorder, hyponatremia. By the end of the video, you will understand definition, causes, and clinical features, and importance of SIADH, pseudohyponatremia, and their classification and management. Okay, so let's begin first with definition. What is hyponatremia? So serum sodium less than 135 millimole. It's called hyponatremia. So serum sodium less than 135 millimole is hyponatremia. We are going to focus on hyponatremia because hypernatremia everyone can easily manage easily, but to manage hyponatremia it's very serious and difficult. So normal serum range is 135 to 145 millimole per liter, and here, okay. So sodium is one of the major extracellular cations. It plays a role in fluid balance, osmolality, nerve function, muscle function. Everything is similar to potassium. Potassium is intracellular major and sodium is extracellular major. This is the difference. And a fall in sodium causes water to move into cells. Okay, and we have to know everything. So I'm going to clinical features next. Clinical features we need to know based on severity and speed of onset. So mild hyponatremia may be completely asymptomatic. So often asymptomatic, nausea, headache and fatigue and weakness. Okay. As the sodium falls further, patient may develop headache and nausea. Okay. Weakness and confusion in moderate actually, and irritability, poor concentration, and gait disturbances. In case of severe hyponatremia, seizures are most commonly presented, and reduced consciousness, and coma, respiratory arrest, vomiting also can be done. Additionally, I will be writing here respiratory arrest. Okay. So most dangerous consequences is cerebral edema. So you have to know cerebral edema is most danger due to water entry into brain cells. Okay. The causes of hyponatremia. Causes of hyponatremia. There are two causes. Sodium loss due to decrease in total body sodium, and water excess. So there will be a increase in total body water. Okay. And in decrease of total body sodium due to medication. Previously, we have discussed about diuretics. That just a minute. NaK2Cl. So Na is sodium and K is potassium. So hyponatremia, hypokalemia, and hypochloremia. So this actually works by disturbing this NaK2Cl, and eventually hyponatremia develop, and hypokalemia also develop, hypochloremia also develop. So you have to know this. And second is Addison's disease. Okay, due to adrenal insufficiency, cerebral salt wasting, and this is renal failure due to salt wasting phases. Okay. Next is extrarenal sodium loss we need to know. In extrarenal sodium loss, we have to think about this is actually alkalosis, and this is acidosis, diarrhea, acidosis, vomiting, alkalosis, and excessive sweating, burns, and villus adenoma of rectum. So we need to know these two causes. And next is water excess causes. In water excess causes, you need to think about SIADH. There is a superb mnemonics in this slide. I will be explaining after two slides. And CNS disorder may be presenting with stroke, infection, and trauma. Malignancy, especially small lung cancer, and drugs which is SSRI, carbamazepine, cyclophosphamide, etc. Pulmonary disorder is pneumonia, TB, and post-operative state also we can see SIADH. I will be explaining you the mnemonics in within two slides. And the second causes is hypothyroidism, okay, and heart failure also may be one of the reason, okay. And next is adrenal insufficiency, we discussed here, adrenal insufficiency, and cirrhosis also. And next is renal failure, excessive IV dextrose, and psychogenic polydipsia. So there is pseudohyponatremia, we have to know about it. In pseudohyponatremia, if sodium appears low on laboratory testing, sodium appears extremely low, and however, plasma tonicity appears to be normal, plasma osmolality normal, okay, and patient does not truly have hyponatremia. Patient does not truly have hyponatremia. So actually, you have to know three causes: hyperlipidemia, due to increased lipid in serum. It's commonly seen in diabetic mellitus, obesity, nephrotic syndrome, and hypothyroidism and liver disease. Okay, it's seen in another thing you have to remember, hypoproteinemia. Second thing, hypoproteinemia. So result in hyperlipidemia may be plasma water by excess lipid, falsely low measured sodium. Okay, and similarly hyperproteinemia, increased protein in serum, so which may cause multiple myeloma, Wilder storm macroglobulinemia, and severe dehydration, which increases protein. We have to know this. Okay, dilution of water, plasma water by excess protein. Everything is dilution of plasma water by excess lipid, excess protein, and here in excess immunoglobulin displays plasma water. So everything is falsely measured sodium. Okay, falsely measured sodium. Nothing is true. On direct ISI method, sodium is normal. Okay, you have to know this. So classification of hyponatremia, we have to see group 1 is by serum osmolality. Have to know serum osmolality is lesser than 275. Hypotonic, isotonic is 275 to 295, and hypertonic is greater than 295. We have to know this. And pseudo hyponatremia has a normal osmolality. Okay, we have to know. This is we have to know about this. And here, decreased effective osmolality due to excess water or sodium loss, most commonly seen. And in isotonic, normal osmolality due to increased lipid and increased protein and increased immunoglobulin. We have to know. Okay. Next is effectively hypertonic is actually translocational hyponatremia, which is effectively osmolality due to osmotically active substance, glucose or mannitol. So here hyperglycemia is most common cause. Okay, and coming back to extracellular fluid volume status. Okay, most likely examiner will ask you this as a main very important main. Okay, hypovolemic, you have low decrease total body and total water body and decreased sodium, which may cause vomiting, diarrhea, and skin losses, sweating burn, and renal losses, diuretic salt wasting, nephropathy, and Addison's disease, cerebral salt wasting. Okay, which is here urine sodium is lesser than 20 millimole per liter. And similarly, euvolemic is greater than 20 millimole. And again, hypervolemic is also lesser than 20 millimole, but the causes differs. In euvolemic, it is caused by SIADH, syndrome of inappropriate antidiuretic hormone, hypothyroidism, okay, and adrenal insufficiency, primary polydipsia. We all have learned about this previously. Okay, and next is hypervolemic. Hypervolemic is increased total body water and increased sodium due to heart failure, cirrhosis, renal failure, and excess IV dextrose. Excess IV dextrose. Other than that, you have by duration, most likely lesser than 48 is acute, usually symptomatic, and greater than 48, usually asymptomatic or mildly symptomatic. You have to know. I said that I will be taking mnemonic for syndrome of inappropriate antidiuretic hormone. So here, this is one of the important. cause of hyponatremia. And the SIADH stands for I is INA, increased sodium, and P is nothing but plasma urine. Okay, plasma urine increase. Okay, you have to know. Hmm? Very easy. This is. And you have to know about classic laboratory finding is low serum osmolality, high urine osmolality. Okay, blood low serum osmolality and high urine osmolality and high urine sodium. Okay, urine sodium is increased and urine osmolality plasma is increased. So patient is usually euvolemic and classic exam association. Definitely examiner will also give you squamous, not squamous, small cell carcinoma. Just a minute. Small cell carcinoma lungs. Okay. So examiner will always give association with INAP. IN means increase, Na means sodium, increase sodium in urine, and plasma osmolality also increase. You have to think this. Okay, this is very easy. And yeah, rest of all I have given same. So here water excess, this is hypervolemic and edematous, we have to know. And the body contains too much of excess water and water retention exceeds sodium retention. Therefore, serum sodium falls here. Common causes you have to know all those here. Renal failure can be one of the cause. And clinical clues they will give you as peripheral edema. Let me write peripheral edema, ascites, okay, and rice, JBP. This three are clinical clues they will be giving. And from the exam point of view, most common surgical causes also they may be asking. In surgical causes, hyponatremia is due to this thing, IV, dextrose, over administration of 5% IV dextrose. Okay, why? Because 5% dextrose behaves like free water after metabolism. Too much of free water dilutes sodium. Always remember this example. Okay, and next thing is diagnostic clue. Is urinary sodium and osmolality level aid in making the diagnosis. You have to know. Management always, before thinking, if your patient is like low sodium 120 millimole, you should never directly aim for correcting to 135 mmol because probability of central fontaine myelinosis. Okay, myelinolysis, I can say myelinolysis. Okay. So this can be due to osmotic demyelination syndrome. It is not easy to reverse once patient develop a central pontine myelinosis. So you should never administer correct falsely from 20 to 135. Your aim for first 24 hours is, I will be writing here. So 120 means 125 first 24 hours, then come back to 130 next 24 hours, then next thing is 135 and above. Not to jump directly from 120 to 135. This is the thing. And you have to know the sodium requirement. As per body weight, you have to know. So for knowing it, 125 minus serum sodium into 0.6 into body weight is the required milli equal of sodium. You have to know. Okay. So let us go for exam memory trick. So as I discussed, pseudo, okay, pseudo means look low osmolality is normal. And next is serum osmolality is normal. Multiple myeloma can be this thing, and hyperlipidemia also can be seen with association. And next is hyperlipidemia and hyperimmunoglobulinemia, okay, and hyperproteinemia also, proteinemia, okay, you have to know this. In SIADH, again, INAPP, inappropriate. Okay, IN means increased sodium in urine and plasma osmolality in urine is increased. So that's all. Sodium osmolality, serum osmolality decrease, urine osmolality, plasma, okay, increase. Urine sodium is also increased, and euvolemic patient and think small cell lung cancer. You have to know. We will be resuming with questions now. So first question is 72-year-old man is admitted with lethargy and dizziness. Okay, he has been taking hydrochlorothiazide for hypertension, and examination revealed dry mucus and postural hypotension. Blood test reveals sodium is 122 here, and next is serum osmolality is 265 milliosmolality per kg. Urine Na is 8 millimole. What is the most common likely diagnosis? Most likely diagnosis. So from the sodium level is actually 122 millimole, and there is a low serum osmolality here, okay, which is 265. Okay, and there is a urinary sodium is also low here, and from here I can say there is a dehydration. So the clue point is also hypovolemia plus urinary sodium less than 20 here, but 8 is only present, so extrarenal sodium loss can be seen. So your answer is hypotonic, hypovolemic, and hyponatremia. In second question, 68-year-old man with small cell lung cancer presents with confusion and headache. Confusion and headache. Again, sodium is decreased 118. Serum osmolality is 255. Okay, so this is low serum osmolality. Okay, and urine osmolality is 600 milliosmolar per kg. This is high urine osmolality, and urine sodium is 40 millimole. So again, high urine sodium. So what could be the association is small cell lung cancer. So this is SIADH entire scenario. So INAPP again. So INA means increased sodium in urine, and PP is plasma osmolality in urine, which is 600. So yeah, 75-year-old woman with known multiple myeloma attends a preoperative assessment, okay, clinic, and blood test shows serum sodium is 120 millimole, okay, and next is serum osmolality is 285. Remember 275 to 295 should be this in pseudo hyponatremia, but here you have 285. This is itself a clue, and associated with multiple myeloma. Okay, multiple myeloma. So multiple myeloma increases serum protein, causing a falsely low sodium measurement. This is the key clue, and you can see normal serum osmolality and normal urine studies. Okay, normal serum, normal urine, and urine osmolality is also normal. So you can. This is the thing you need to know. Pseudo hyponatremia. Question number 4, 60-year-old woman with a severe hypertriglyceridemia. Okay, glyceridemia. This is one of the important clue. And anything presents with triglyceridemia and proteinemia and hyperimmunoglobulinemia. Close your eyes and mark pseudohyponatremia again. Pseudohyponatremia. Okay, and sodium is again 124 millimole. Okay, and she is asymptomatic and serum osmolality it is normal. Next question 5. A 55-year-old man receiving a large volume of 5% dextrose following a major abdominal surgery. 2 days later, he develops a confusion and lab results showing 119 normal this thing. Sodium is 119 and serum osmolality again 260. So again, this is there is a surgical pulse here. Large volume of 5% dextrose. I have discussed previously. This is over administration of 5% dextrose. So which causes sodium to be 119 millimole. So over administration of 5% of dextrose. Question 6. We have a 67-year-old man with a congestive heart failure, presents with ankle swelling and breathlessness, and blood test reveals sodium is 125. Okay, and you can see serum osmolality is 260. Okay, and on examination edematous. Okay, edematous. And what type of hyponatremia is more? Edematous is there is a water retention. So ultimately, the answer could be hypotonic, hypervolemic due to water, using edematous, and hyponatremia. Okay, and there is a heart failure also. So you have to know dilution of sodium. Question 7. 58-year-old diabetic patient presents with a polyuria and confusion. Okay, and lab results reveal glucose is actually 38, sodium is 124, and serum osmolality 320 increase. And what is the likely diagnosis? Typical finding is glucose increase, sodium is actually decrease, and osmolality is increase. So this could be actually hypertonic hyponatremia. Okay, why very high glucose causes water movement from cells to plasma. So this dilutes sodium despite increased serum osmolality. So hypertonic hyponatremia. So question 8 is very easy because sodium is 112. Okay, so which of the following is most feared complication of overly rapid correction? So ultimately your answer is central pontine myelinosis. Rapid correction we should not do. So it may also features dysarthria, dysphagia, quadriplegia, and locked-in syndrome. Again, dysarthria, dysphagia, and next is quadriplegia. Okay, and locked-in syndrome. For first 24 hours, always 5 to 10 millimole per liter. Okay, for first 24 hours. Okay, question 9. This is actually hyponatremia, low serum osmolality but high urine osmolality and high urine sodium. So in a PP. Okay, increase sodium in urine and PP again. So PP is plasma osmolality. So again, this is SIADH answer. Question 10. So 74-year-old woman with severe hyperlipidemia referred to a evaluation of a sodium level 121. Okay, she is completely asymptomatic and repeat testing confirms normal serum osmolality. And which of the following best explains the lab abnormality? Here I can say lab here severe hyperlipidemia causes falsely low sodium measurement. Okay, so this is the consideration you have to do laboratory artifact due to elevated lipid. Okay, with this we finished actually the problem. Thank you for your attention. Okay, yeah. So kindly subscribe my video for upcoming topic, and please like, share and comment your doubt.